Okay, we are on part 2. I hope you don't have any major concerns about part 1, but if you do, you let me know, and I will be glad to go over it with you. In fact, we now have Blackboard Collaborate, where I can actually set up one-to-one conference with you, and you can see me, and I can see you, and we can ask questions, and we can do that online. So let me know if you want to take advantage of that, if you're having trouble with any of this content, and I'll be happy to get back with you. Alrighty then. So we got to fast fact sheets, ventilator settings, mechanical ventilation. And it's on pages 614 through 622 in your med-surg books. And we are actually going to start on page 616 with mechanical ventilation. So what is the goal? Why do we put someone on a ventilator, and how do we know which one to put them on? And before we do that, let me ask a couple more quick questions in here to make sure you remember from last semester. What's the normal dose of Tylenol for a ped? 10 to 15 milligrams per kilogram, right? Every 4 to 6 hours. 10 to 15 milligrams per kilogram. Ibuprofen, what's the normal dosage? Remember, depends upon the temperature. 102.5 is your cutoff. Anything greater than 102.5, 10 milligrams per kilogram. Anything less, 5 milligrams per kilogram. And if you're giving ibuprofen for pain, it is 10 milligrams per kilogram. Okay, just to let you remember that. I also posted tanners in case you forgot tanners. There may be a tanners question. And I know sometimes you think, oh my word, would she please just leave the old content alone? And the answer is no. And the reason why is you'll forget it. And I know that. So repetition's the mother of all learning. Okay? So why do we put someone on a ventilator? Well, we want to improve gas exchange, right? Oxygenation. Or it could be to decrease the work needed for effective breathing pattern as well. So our whole goal is to get them healed and then back off the ventilator, right? So how does mechanical ventilation differ from normal breathing? Well, if you look on page 616, it does talk about mechanical ventilation, and it talks about the role of prevention of problems while they are on the ventilator. And then it gives you this handy-dandy little italicized thing that says, a ventilator does not cure diseased lungs. It provides ventilation until the patient can resume the process of breathing on their own. So that's what it's all about. If you look on page 617, it gives you the best practices, again, for patient safety and quality care, QSIN, and safety is a big thing, and for care of the patient receiving mechanical ventilation. So you want to go through there and review those. You don't have to study them in depth, but make sure you do know that, you'd want to give someone mouth care every 2 hours. You'd want to do I know. You'd want to make sure they're getting turned every 2 hours. You'd want to make sure you're assessing their respiratory status every 4 hours until stable. And then once they're stable for the first 24 hours, it's as needed. And sometimes it's still every 4 hours. That you're checking those ventilator settings at least at a minimum every 8 hours, if not more. So it's just generally studying those things and common sense, really, of what you would want to do. Now, how does the mechanical ventilation differ from normal breathing? A ventilator pushes warm, humidified mixture of oxygen and air into your lungs. And what's that do? Creates a positive pressure in the thorax during inhalation. Think of it as blowing up a balloon or many tiny balloons. This is different from our normal lung mechanics in the sense that our normal breathing creates negative pressure in the thorax. So think of your normal breathing tendencies, okay? It's kind of like accordions, okay? That's your normal breathing tendencies. So it works to help give, again, extra pressure to help them with their breathing, and it can breathe totally for them, or it can assist with their breathing. So you've got types of ventilators and modes. The new age ventilators actually have all the following modes and are not restricted to just being one type or another. They are very small now. There's an excellent picture on page 617 that shows you an actual ventilator setting. And all the settings are right there on a almost like laptop experience or computer screen. So we don't have these big bulky machines that we used to have years ago. They are quite condensed now. So when we're talking about types of ventilators, and then we're going to talk about modes of ventilators, these first three are considered types of ventilators. You need to know those, and you need to know the last ones are modes of ventilators. So when we're talking about types, it can be pressure controlled, volume controlled, or pressure regulated volume control, PRVC. That is most commonly what you're going to see the setting on, particularly at local hospitals. The pressure control means the pressure is the endpoint instead of volume. So when you're doing inspiration and it ends when that preset pressure is released. Let's say you've got your pressure set at 400, 500, whatever. Once that pressure is released, that breath is done. The insulation's done, regardless of how much volume it's delivered. Where volume control, the ventilator is set to deliver a preset volume of oxygen and air called tidal volume, regardless of the amount of pressure required to deliver it. It may not get to its full pressure. Once you get that volume, it cuts off. And then you have the combo, the pressure regulated volume control. And it adapts to change in compliance of your lungs to adjust to the inspiratory time and pressure needed. So you have a preset tidal volume, a preset pressure. And it works by making sure that you have those before the next breath is delivered. So it's the combo. So those are the three. Again, this one being the most common that you're going to see. Then you've got assist control, SIMV, synchronized intermittent mandatory ventilation, BiPAP, and Cpap. These are your modes. Now, mainly when we talk about assist controlled or AC, and these are also covered in your book down on page 616 and 617. The modes, the first thing again, assist control. Now with assist control, the ventilator is supporting every breath, okay? It's doing all the work for you. So who do you think would need to be on assist control mode? Well, someone who can't breathe, right? Someone who's been resuscitated and is still not breathing on their own, but they have a pulse. Someone who's got full-blown ARDS, who's not having adequate oxygenation, breathing on their own. Someone who's paralyzed, heavily sedated, and hasn't come back out of it. Those would all need you to breathe. I certainly hope that the machine's breathing for me when I'm totally sedated, right? And helping me. Synchronized intermittent mandatory ventilation, SIMV. Not all your breaths are assisted. Okay, up here they're all assisted. With SIMV, not all of them are assisted, leaving you to actually draw some breaths on your own. Where up here on AC, you don't draw any on your own. The machine does everything for you. So who would need this type of mode, do you think? Well, patients who need short-term ventilators, right, would benefit from this. Patients, as they're beginning to be weaned off of a ventilator, are a lot of times put on SIMV mode to see how many breaths they're doing versus how many the machine is doing. BiPAP and Cpap, a lot of times they are giving this as they, again, weaning them off as well. BiPAPs are really non-invasive pressure supports that you get with a mask. Usually a lot of times used with sleep apnea and patients who have who need ventilator support but without the need for intubation. So it will be someone who needs that extra boost, that extra air without being actually intubated. Your Cpap is your continuous positive airway pressure. This is also non-invasive pressure, supported by a mask, or it can be also a ventilator. A ventilator has the setting for Cpap that you can put them in that mode. This is mainly used for sleep apnea or someone, again, who's being weaned off the computer and weaned off the computer. I need that. Weaned off the ventilator and just needs that extra boost to keep them going. Their alveoli may not be open quite all the way, so it gives them a little bit extra boost with every breath, but they are breathing on their own. Now, ventilator controls and settings. These are covered in your book on page page 618. So read over those. But you got tidal volume. Now tidal volume, you'll see that as a big V with a capital T in the lower area, subscripted. That means tidal volume. And this is the volume of air that the patient receives with each breath. And it varies from patient to patient. It can range anywhere from 7 to 10 milliliters per kilogram of ideal body weight. One of the things the book tells you, even though research does not support this, is add a 0 to the weight of the patient in kilograms. I'm going to give you an example of why you want to be a little careful about doing that. But it will give you an estimated. For example, if you had a patient who was 5'4" and their ideal body weight they had an ideal body weight of 135, that would be 61 kilos. Well, the high end of the safe tidal volume for that is 610 mils, which is a lot for someone who only weighs 135. If that same female who was 100 pounds overweight at 235 weighed 107 kilos, that would be about 1070 tidal volume, and that's way too high and dangerous. That could actually cause trauma to the lungs and possible cause of a pneumothorax. So the heavier you are and you have to weigh those, and you weigh more kilos, it's really putting you at a higher end of danger. So you want to be very careful by just adding the rule about adding a 0. It's really better to do 7 to 10 mils per kilo of the ideal body weight. But most of the times with tidal volumes, you're going to see them set at about 500. Now, your heavier patients may be 600, 700, but most of the time, 500 is a good number that you'll see. What about rate or breaths per minute? This simply means the number of breaths per minute that ventilator is going to deliver for you. Normal setting is 10 to 14. You need to know all this I'm talking about. Fraction of inspiratory oxygen, which is known as FiO2. That's the amount of oxygen the ventilator is going to deliver, and that varies depending upon the type of ventilator and what setting it's on, but it can deliver between 21 and 100%, whatever the patient's needing. Peep is positive in expiratory pressure. This is similar to Cpap, except it's and BiPAP, except it's through the ventilator. It is used, or similar to BiPAP, but on the ventilator. It is used to increase oxygen in any mode. So no matter what of these modes we talked about earlier, whether it be AC, SIMV, all those, you can add the little peep to it. And think about blowing up that balloon and not letting it completely deflate before blowing it up again. Most patients start out with about 5 centimeters of PEEP, and the usual range is 5 to 15. It could possibly be a little bit higher, but you're going to see usually PEEP set between 5 and 15 centimeters. And it's just giving those alveoli a little extra boost at the end to open them up. Positive in expiratory pressure. Flow is how fast each breath is delivered, and usually set at about 40 liters per minute. Some start at 60. Cpap, again, is applying positive pressure throughout the entire respiratory cycle for spontaneous breathing patients. So it's helping through the inspiration and expiration, whereas PEEP's at the end. This is most commonly used to assist, again, in weaning process because no ventilator breaths are delivered. You're just giving them an extra boost in and an extra boost out. Normal setting is 5 to 15 centimeters. All right, so if you have any questions about the ventilators, the types, which is pressure controlled, volume controlled, and pressure regulated, PRVC, which is the most common, the modes, AC, SIMV, BiPAP, Cpap, let me know, or any of the controls and settings that you need to be familiar with before you go to the unit. Now, what about weaning? How do we get them off this big old machine? If you look on page 622 in your book, it gives you weaning methods, okay? And the process of going from a ventilator-dependent to spontaneous breathing is considered weaning. Weaning, when we talk about all of these, the most important prerequisite to weaning is improvement in their original problem or reversal of that underlying condition, which we see there under indicators to document for weaning. So if they are improving, they come in with aspiration pneumonia, their lungs have cleared up, they're doing much better, then that's an indicator they're ready for weaning. So I'm getting ready to wean them, and I can use 3 major methods, the SIMV or the Cpap. And again, that's when you're just using the ventilator, the SIMV mode, to assist them in their breaths, right? CPAP's when they're totally doing it on their own. You're just giving them a little more oomph during the respiratory cycle. You can also use the T-piece technique. And this is when the patient is taken off the ventilator for short periods, maybe 5 to 10 minutes. They breathe spontaneously. Then the ventilator is replaced with what we call a T-piece, and you can read more of that in Chapter 28, or Cpap. And they start the weaning process gradually until they give them longer and longer time off the ventilator in between that. So it's kind of like a bowel retraining almost technique. And then pressure support ventilator. This involves the patient's respiratory effort to be augmented by a predetermined pressure. As the weaning process ensures, the amount of pressure applied is starting to be gradually decreased. So you start out with a certain pressure and you just gradually decrease that pressure until they are breathing on their own. So those are the 3 major methods of weaning. Now, indicators to document for weaning. How do I know someone's ready for weaning? Remember what I said the number 1 thing was? Reversal of the underlying condition. Reversal of the underlying condition, number 1 thing. Also, you need to know these. Spontaneous respiratory rate would be important. If they're not breathing on their own, they're still very heavily dependent on the ventilator, they don't need to come off. They need to be hemodynamically stable. So if they've got some kind of hemodynamic monitor in and their readings are all unstable, they don't need to come off yet. Acceptable acid-base balance and oxygen status. Okay, if they're still in respiratory acidosis and it's severe respiratory acidosis and their O2 level's low and they're not satting good, they don't need to come off. What we call a rapid shallow breathing index, or an RSBI. And this is one of the more accurate predictors of weaning success, how they're going to do successfully once they get off. The RSBI is determined by dividing your respiratory rate by your tidal volume, okay? And if it's less than 105, they have a high probability of success. If it's more than 105, they have a low probability of success. So you want to see a lower number. So anything less than 105 is a good indicator. And that's mainly what you need to bring away from rapid shallow breathing index. There's a way to figure it, but you're looking at that number being less than 105. Renal and cardiac stability. Of course, if their kidneys are shut down and they're not perfusing well, or their cardiac output is decreased and they're not stable, then they don't need to come off the vent. Minimal sedation. If they are still having to have a lot of heavy sedation, they don't need to come off the vent. Adequate nutrition, we know that's important. That's why we make sure that they are getting either parental or some type of feeding, tube feeding, something while they're on the vent. And ability to manage secretions. If they can't manage their secretions and they may get choked on them, they can't cough them up, then that's another reason to keep them on the vent. So you need to know the indicators to document for weaning. Nursing management, you want to be concerned with the patient first and the ventilator second. Always monitor and evaluate your patient. So if you go in, the ventilator's beeping, first thing, look at your patient. If they are in distress, do something, okay? Managing the system safely, very important. Preventing complications, how do we do that? Well, we can prevent infections. We can prevent atelectasis from occurring by watching certain things, barotrauma, making sure that we're listening to the lungs, that they don't have decreased breath sounds, that we haven't caused some kind of trauma. Oxygen toxicity, that we haven't let the oxygen level get so high that they become toxic. And just using overall good pulmonary hygiene, okay? Suctioning, we're going to cover that here in a little later. So I will cover that with you later. Again, nursing interventions for various causes of ventilator alarms. So the ventilators are set, and they will preset these, and they have a high volume or high pressure alarm and a low pressure alarm. And they preset these to go off at certain times if they get too high or too low. So on page 620, if you look at that, these are the most common reasons and what you would do if they do go off. So please know these. For high pressure alarms, that means the pressure limit has exceeded what you set it at. That's usually caused by either bronchospasms. They could have the ETT tube could be kinked, or they could be biting it. So I always want to check that. They could be full of secretions and need suctioning. Pneumothorax could have developed. Listen to the lungs. They could be fighting the vent and need sedation. They may be coughing very heavily, and it's caused that high pressure alarm to go off because the coughing has exceeded and made the pressure go up. All of those really make sense if you think about it. So what do we do as the nurse? Well, we always assess the patient. You know, are they coughing? Well, if they're coughing, that's probably one of the high pressure alarms going off. If they're not coughing, is there kinks? Are they biting it? Okay. Did they just get through moving or turning on their side? Okay. So you want to make sure that you are really looking for the reasons of why that high pressure alarm is going off. Look at the monitor. Do they have a change in their condition? You know, are they blue now? If they are, then that's a bad thing. If they were coughing very heavily and now they're not coughing very heavily and the monitor's quit beeping, then it's okay. If you're not sure if they need suction, then pass the suction catheter. Okay, make sure there's no airway obstruction. And you can always take off and bag them if they get in trouble. If you absolutely can't figure out what's going on and they're turning blue, then take them off the vent and start bagging until you do figure out what's going on. Okay, that's always an option. That's why you always have that at the bedside. Low pressure. Pressure limit goes low. Well, usually that's because something's become disconnected or there's a leak. It's one of the two. Something's disconnected or a leak. So what are you going to do? First thing you're going to do if the low pressure alarm goes off is assess all your connections. Start backtracking, making sure everything's connected. Make sure you're checking that cuff on your ET tube, that there's not been a cuff leak. And we'll be talking about that here in a little bit. And again, if all else fails, they're getting in trouble, take it off and bag them until you figure out what's going on. I have come up with a series here. Again, we'll let you see this while I'm going over this, but when I finish, I want you to go back to this site and I want you to view it. And if you can't view it, then you can copy and paste this link in there. It's just a wonderful series on the ventilator and how it works, and it really puts it in plain, simple terms. Okay, you won't be sorry you watched it. All right, so endotracheal intubation and extubation. Very important to know about. So what are the goals? Well, we want to maintain, again, a patent airway. We want to provide a means to remove secretions and provide ventilatory and oxygen as needed. Indications, it could be a renal failure, acute renal failure that could be a reason someone needs intubated. Suctioning and pulmonary hygiene, hypoxia, someone who's had progressive hypoventilation with respiratory acidosis. There's lots of different indications. Are there any contraindications to putting an ET tube down someone? Yeah. Massive facial trauma, someone who's been in a motor vehicle accident who has massive facial trauma, or someone who's had immediate post-op neck or throat surgery. Of course, you wouldn't want to be messing with that and intubating. Considerations, in that case, you would have to probably do a trach. Remove their dentures. So if they've got dentures, you want to make sure that dentures are removed. Now, nurses do not intubate unless you're ACLS certified or better, or higher a certification, or better. So most of the time at the ADN level, you're not going to be performing a lot of intratracheal intubations. You will be assisting with them, which is what we need to make sure, and taking care of them, that you understand. But they're going to remove the dentures, they're going to put on a lubricant, and they're going to check for air leaks. Now, a tracheostomy is considered if the patient requires an artificial airway for longer than 10 to 14 days. So if they know that this patient's going to be on 14 days or it goes past 14 days, they will put in a trach. And the reason they do that is to reduce tracheal and vocal cord damage, because that is more than likely if you leave it in past 14 days. So the endotracheal tube, it is passed through the mouth or nose into the trachea. When would you use the nose versus the mouth? Again, facial trauma, oral surgery, throat surgery, neck surgery, you may use the nose. The tip of the ET tube itself rests at about 0.8 to 1.2 inches or 2 to 3 centimeters above the carina. Why there? Well, it's to avoid the bronchus, because right past that, you're going into the bronchus, and the bronchus bifurcates and goes to the right or the left main stem. And most of the time, if you go past that, you're going to go into the right bronchi. The carina is the point at which the trachea divides into the right and the left main stem bronchi. This is used in emergency situations only, that you're going to have to see someone intubated, usually during a code, usually respiratory, the physician, someone's going to intubate. Out on the field, it would be paramedics. And what are the parts of the ET tube? It talks about that in your book. It's on page 615. So you can review the parts of the endotracheal tube. It also shows you the endotracheal tube on page 615 and what it looks like. The adult size ranges from 7 to 9. 8 is the most common size. And you can go by the size of their pinky finger as well. And you kind of have to guess. Or the size of their nair to determine it as well. But 8 is the most common. In a child, usually less than 10, use an uncuffed tube or do not inflate the cuff. And why do we do that? Because the airway, if you remember, is very narrow. We talked about that in growth and development. It doesn't take much to clog it off, any kind of edema. So it's got enough there that it forms its own seal and own stability. Otherwise, tissue necrosis can develop. Intubation should take no longer than 30 seconds. When you see someone intubating someone, after that time frame, they always need some oxygen. You may be the one giving them some extra oxygen in between the time. You may be asked to apply cricoid pressure, even though we're getting away from applying that during intubation. But all you're doing is going on the carina on each side of the cricoid and pushing downward. And what that does is occlude the epiglottal opening to prevent vomiting and aspiration during the actual insertion of the tube. So how do you determine correct placement of an ET tube? Well, the first two are the most accurate methods of verifying placement, and that would be, a chest x-ray. It will show you where the tube is landing. And where should that be? 2 to 3 centimeters above the carina, right? In tidal carbon dioxide level, gold is good. And I will show you that I will show you what I mean by that here in just a little bit. What they will do is put a CO2 detector on the end of the tube. As you're breathing out, they'll take you off for a minute and put that on the end of the ET tube. And the color will change, and they will see what color you fall in there. And gold is always good. Assess breathing patterns bilaterally. Assess for symmetrical chest movement, of course, once you put it in and you want to make sure it's in correct placement. Both sides of your lungs should be moving simultaneously and bilaterally. Auscultate over the stomach. You want to make sure you don't have it in the stomach, because you can have esophageal intubation. If the tube is in the stomach, you're going to have louder breath sounds that are heard over the stomach than over the chest, and the abdomen's going to become distended because it's blowing up in the abdomen. If breath sounds and the chest wall movement are absent on one side, then the tube may have went a little further and actually be in the right main stem bronchus. So if you got the left side not moving and you can't hear breath sounds, then pull it back just a little bit, because you probably went down into that right main stem bronchus, and they will hear it on both sides. Now again, the person who's intubating will be the one doing all of this. Your big thing is nursing management of the patient receiving mechanical ventilation. And you do want to know where it should land, about 2 to 3 centimeters above the carina, and how to make sure it's in place. Of course, we've already said the most accurate thing is what? Chest x-ray and in tidal volume CO2 expiration. So what are we going to do? We're going to stabilize the tube and assess for placement. So once the tube goes in, it's always marked at the level where it touches the incisor tooth or the tip of the nair. If you start changing this out, then you always want to have 2 people, one to secure it while you're changing the ties. Now, we don't use ties as much as we do Velcro now. Back in the old day, we had to have someone hold it while you tied the string and then went to the other side and hurried up, tried to tie the string so that they wouldn't cough out the tube or anything. It's much better and easier now with the little Velcro strips. Chest x-ray every morning in most facilities to maintain placement, so that would be something you'd want to make sure, if that's your policy, that you are doing and making sure that's in place every day. You always want to see where it was marked and make sure that tubing is still where it should be at about the incisor tooth or about or the lip or nair. Mouth care every 2 hours or per policy. Assessing for complications is part of making sure when that's in there that it doesn't slip down into the right main stem bronchus, or that they're not developing complications from the tube being in, like necrosis on the side of the mouth. You want to make sure you're moving that tube, ET tube, from side to side per policy. Weaning, you're part of the weaning process and making sure that they're doing good during the weaning process and keeping the physician updated on how well they're doing during the weaning process. The ventilator settings, knowledge is power, guys. Knowledge is power. I have told you all about the ventilator settings, so study up on those, particularly before you go into the unit. Now, communication can become a problem. It is your responsibility to make sure that you are communicating with this patient effectively, that you do their method of communication. Some like the board, some like pictures that they just point at, some like to write you stuff. So you want to make sure that you have some method of communicating with that patient and family support while they're on the vent. Sterile suctioning, only 10 seconds at a time. Evidence-based practice also says normal saline, helpful or harmful during suction, and it says harmful. It's better now not to drown someone prior to suctioning them. Years ago, we used to go in every time we suctioned and squirt saline down their throat and then hurry up and try to get it all out. And now they say it's better not to use it. Again, once daily, you're going to move that tube from side to side or per policy. Because if you've ever seen one, it's kind of tight there in the crack of the mouth, and you wouldn't want it to get to where it causes necrosis. You also can be responsible for measuring cuff pressure. It should be at about 10 to 25 centimeters of water, and they have little cuff pressure measuring devices in all the units that they just put up there, and it measures it. It's called this manometer, and it checks the pressure that stays connected to the ET tube and measures it. And again, the first time you do that, of course, you want to make sure your nurse is doing that and you're observing so that you know how to do it. The worst thing you'd want to do is let all the air out and the tube fall out. So you want to make sure that that pressure, though, is staying, that bulb that you have blown up in there is staying up to about 10 to 25 centimeters of water. Restraints are always a last resort, but sometimes you do have to have those with people in the vent because they fight it so bad. Most of the time, restraints on the vent is considered sedation time. Again, make sure you review the chart about best practices and safety for a patient receiving mechanical ventilation. So, now we've got them all better and we're ready to extubate them. We always want to explain the procedure prior to doing that. Respiratory will be the one usually that extubates. The head of the bed is usually up to prevent aspiration. A lot of times the nurse is just present at the bedside to make sure everything goes okay. Respiratory is usually going to suction them prior to pulling the tube because you wouldn't want to deflate that balloon and then have a bunch of secretions around it and it all go down into the lungs. You also want to be ready to suction afterwards as soon as the tube comes out. So we're going to hyperoxygenate prior to pulling the tube and after pulling the tube. They're going to deflate the cuff and remove the tube at peak inspiration. So during peak inspiration, they're going to deflate the cuff and remove it. They're also going to instruct the patient to cough as soon as they take it out. So while they're coughing, you're going to be suctioning, giving oxygen by mask or nasal cannula with high humidity. You're going to be monitoring for complications and educating them, especially the patient, that they, for example, that they may have a sore throat for a few days. Memory may be fogged while they were on the vent a little bit. But talking about memory may be fogged, you want to make sure you realize when someone's on a ventilator that hearing is the last to go. So be careful, little mouth, what you say, as I posted. Because the worst thing you can do is have a patient come off a vent and start crying on you because of all the horrible things they heard nurses saying, or the things that, you know, the stories that went on in the room. They could care less what you did over the weekend. So just be very, very cognizant of that. When it says monitor for complications, that would be like shortness of breath. If they get off the vent and start having increased shortness of breath, coughing, stridor, you know, then they may have to go back on the vent. So it's the nurse's role to always make sure how they are tolerating being off the vent and being weaned, and making sure they don't need to go, showing signs and symptoms they need to go back on the vent. All right, thank you very much. I hope you enjoyed this section. If you have any questions or concerns, let me know.